So we have discussed the possibility that organ protection may be complicated or even impossible in some cases, while early identification is probably the most important solution. That's why we created the so-called Biomarker Alliance, which put together clinical chemistry, laboratory medicine, and clinical nephrology. And after the discovery validation of the biomarkers, we wanted to see how much was possible to make a clinical implementation and do routine adoption of biomarkers. So what step to do? Well, we did something in order to move from the role of early adopters to the point in which every patient in the ICU or cardiac surgery could have these biomarkers measured and fill the so-called adoption gap. We did a study on health economics in order to see how much biomarkers could pay for the problem of saving a few AKI cases, and I will just skip completely the economical evaluation program that we actually did. The most important thing is that basically we found from an analysis in UK that the cost of AKI was exceeding 1 billion pounds and therefore impacting severely on the national health system budget. For this reason, we carried over a study in conjunction with our administration at the hospital, assuming that we could reduce a certain amount of AKI cases or patients undergoing renal replacement therapy that would pay for the cost of the biomarkers. And we used the NephroCheck test for providing the information that we wanted to apply. So this was our layout of the study. At the beginning, we studied the sample of 316 patients, building a model for prediction of AKI after cardiac surgery and then in ICU as well. Then applied the model to a cohort of patients with equivalent characteristics, and that was a sample of patients that has been later on expanded. And finally, adding NephroCheck, testing whether there is additional value of the biomarker to the clinical model. So it was constructed a logistic regression model to estimate the probability that the patient develops AKI after cardiac surgery. And basically, we had variables from preoperative, intraoperative, and postoperative for cardiac surgery. Now, I go straight to the point. There was a significant prediction ability from the risk model that was created. But after testing the NephroCheck in a similar population, what we actually got, and I can go straight because of time, to the point in which we could significantly improve sensitivity of the area under the curve, and practically the additional value of NephroCheck was demonstrated. So in conclusion, what we had was that NephroCheck was adding value to our detection capability of risk of developing AKI and predicting capacity of AKI. So basically, this improvement may result in clinical practice on early identification, preventive measure, protective measure, implement KDIGO guideline much earlier, and reducing incidence and severity. So, at the end of the story, reducing the cost. In order to do this on routine adoption, we created the so-called Nephrology Rapid Response Team, which is basically a group of nephrologists permanently on call that are alerted when there is a patient in cardiac surgery or ICU They use the F4 model, which is clinical scenario, past history, physical examination, lab results, including biomarkers. They apply this thing with the specific checklists, and then they score the patient for low, high, or moderate risk for AKI, and then biomarkers are added to the equation, activating the so-called nephrology rapid response team, which is intended to stratify AKI if present, avoid AKI if possible, or avoid evolution, to find the cause and possibly follow up the patient at discharge to avoid other episodes. So currently, we wanted to implement electronic system alarm, and basically we have a message of the critical value communication directly to the telephone of the ICU doctor. At that point, the doctor has two options, and we have applied both of them to create checklists and to follow specific bundles. This, unfortunately, is in Italian because we operate in Italy, and this is the checklist that the physician has to do, while this is the bundle, which basically is implementing KDIGO guidelines for prevention protection. However, you will be surprised by doing a checklist and a bundle how many times people notice that they forgot to do this, they forgot to do that, and with the checklist there is a consistency of performance in this measure. Now, just to go to the point, in the ICU, in the moment we applied the nephrology rapid response team versus no and RRT, there was a significant reduction in 2016 on the number of cases undergoing renal replacement therapy. The same thing was done in cardiac surgery, and we found a significant reduction, although the numbers are not that great. But at the end of the story, the overall amount in the hospital of renal replacement therapies that were performed was a minus 19.8%. Now, you may figure out that the population was slightly different. This should be studied in a larger cohort of patients, whatever you want. But still, we could demonstrate at the hospital that the cost for the biomarker was paid by this saving amount. So I think that we demonstrated that this is a complex syndrome, and this morning Rinaldo Bellomo showed how many different pathophysiological mechanisms are there. We have pre-existing or concomitant pathological conditions that represent risk for AKI. The intensity of the insult and susceptibility of the kidney play a pivotal role in the development of the syndrome and its characteristic of severity, and the level of insult and severity of illness will influence the balance between capacity and demand of blood purification homeostasis, so that at the end it depends all on the request of renal replacement therapy. We need to recognize patient subsets, risk factor, to use biomarker for risk prediction and early AKI detection, understand precipitating factors, including medication and procedures, optimize treatment strategies using checklists and bundles, and explore new avenues for AKI prevention and organ protection based on pathophysiological mechanism.